Pathophysiology of AKI, acute kidney injury. Acute kidney injury is going to be defined as acute decrease in urine output, right? Anything that decreases urine output. So you can define it clinically as maybe less than 1 cc per kilogram per hour, right, of urine for 24 hours or within 24 hours, or you can look at it as anuria, so no urine output at all, for 12 hours, right? So that is going to be AKI, acute kidney injury. As you can see here from the formula I have here, decreased urine output. Urine output is primarily determined by GFR. That will be the glomerular filtration rate, right? So glomerular filtration, which is one of the first function of the kidney, or one of the first process that leads to urine formation. Anything that decreases GFR is going to decrease what urine output. So decrease GFR here decreases urine output acutely, and GFR is also needed to get rid of plasma, creatinine, and BUN. So if we decrease GFR, we are going to have increase, right, because of inverse relationship, right? We're going to have increase in plasma, creatinine, and BUN. So you can also define acute kidney injury as acute rise in creatinine or acute rise in blood urea nitrogen. Okay, as you can see here, so what is going to be responsible for acutely decreasing GFR is going to be anything that affects the Starling forces working at the glomerular capillary and the Bowman space interface, right? So we have four forces that works here. We have the plasma, we have the hydrostatic pressure of PGC, hydrostatic pressure of the glomerular capillary, we have the oncotic pressure of the glomerular capillary, we have the oncotic pressure of the Bowman space, and we have the hydrostatic pressure in the Bowman space. We need to get plasma right across. So blood is being brought in by the afferent arteriole. When it gets to the glomerular capillary, there will be a filtration pressure, a pressure gradient amount that must be generated here in the glomerular capillary that will lead to the movement of plasma or fluid across the barrier into the Bowman space, and that will be the first step in the formation of urine, right? So two of these four forces, the hydrostatic pressure in the glomerular capillary and the oncotic pressure in the Bowman space, are going to be needed to drive, right, this blue arrow downwards here, to drive fluid across, right? So, and then the other two forces, which is going to be the oncotic pressure in the glomerular capillary, that is caused by protein level, right, protein level in the glomerular capillary, and the hydrostatic pressure in the Bowman space are going to be going in the opposite, pushing the opposite direction, which is going to be the green arrow, opposing the filtration pressure, right? So anything that increases these, right, and decreases these forces below are going to increase GFR. So here, if somebody has AKI due to decreased glomerular filtration rate, we are looking at mechanisms, right? Either something decreasing the hydrostatic pressure in glomerular capillary, something decreasing the oncotic pressure in the Bowman's capsule or Bowman space, something increasing the hydrostatic pressure in the glomerular capillary, or something increasing the oncotic pressure in the Bowman space. Sorry, the hydrostatic pressure in the Bowman space. These are going to decrease GFR, and subsequently they're going to decrease, acutely decrease urine output and increase plasma, creatinine, and BUN, right? So that's going to be the pathophysiology, right, of acute kidney injury. If we want to expatiate, we can divide, right, we can divide AKI, right, into what? Prerenal, based on mechanism, prerenal or causes, renal, and postrenal AKI. Prerenal AKI are going to be things that all of them will have decreased GFR. They're going to decrease GFR. So GFR in prerenal is going to be decreased. The reason GFR is decreased in prerenal is going to be primarily what? Anything that affects, right, anything that is decreasing PGC or increasing oncotic pressure in the glomerular capillary. So anything that is decreasing hydrostatic pressure in the glomerular capillary or increasing oncotic pressure in the glomerular capillary is going to decrease GFR, and that will be the mechanism of what? Prerenal AKI. So we are looking at what will decrease the oncotic hydrostatic pressure in the glomerular capillary is going to be what? Anything that is decreasing blood flow. So mechanisms of prerenal will be anything that decreases blood flow, somebody that's in shock, someone that's hypotensive, somebody that's dehydrated, right? By decreasing static pressure in the glomerular capillary, they are going to be what? Decreasing this, our blue downward arrow, right? That will decrease the filtration pressure, that will lead to prerenal AKI. BUN will be elevated, creatinine will be elevated, urine output will go down in that order. Anything that will things that will increase exertive oncotic pressure in the glomerular capillary are going to be if you infuse somebody with protein, right? Protein infusion like albumin. Somebody that is dehydrated will also have relative increased concentration in albumin, right, in the blood, right? So those we hold, right? Remember, oncotic pressure holds onto water, so it's going to hold on to fluid here, and that will increase our green arrow, right, going in the opposite direction. That will oppose the filtration pressure, decrease urine output, increase plasma creatinine, and beyond in that order. When after filtration here, so if you look at prerenal AKI, what happens with the absorption in the tubules of the nephron after filtration here in the glomerulars, right? We are going to reabsorb sodium. We need to reabsorb things like sodium, we need to reabsorb glucose and those molecules that we need in the body, right? So reabsorption usually takes place around here, right? There should be reabsorption taking place here. Reabsorption. In patients with prerenal AKI, the tubules are still intact. The problem is what? Decreased blood flow or increased oncotic pressure, right? So the renal tubules are still intact. They are working fine. The epithelial cells are fine. So they are going to be able to, the transporters for sodium and glucose reabsorption are still intact. They will be increased, right? There will be normal or intact reabsorption of sodium and glucose in the renal tubules, in the nephrons. Yeah. And so reabsorption is intact, right? Which means that what the concentration of sodium, concentration of glucose in the urine is going to be decreased, right? So you're still going to have intact reabsorption. In renal AKI, where the problem is with the nephron itself, there's injury with the nephron, therefore it's going to be decreased, and it's going to involve multiple mechanisms. Here. Right, so the oncotic pressure can be decreased, the hydrostatic pressure can be increased, right? Multiple mechanisms, right, are going to be any multiple derangement in the Starling forces are going to lead to what? Renal, right? Decreased GFR in renal AKI, where problems with the glomerulus itself or something wrong with the renal tubules or the interstitium of the kidneys or the blood vessels itself, right? Yeah, in this case, reabsorption is going to be affected. The absorptive function of the kidney is going to be decreased, right? Because we've damaged the renal tubules. So this will not take place. The channels are damaged, reabsorption is decreased, right? So we're going to see increased sodium, increased glucose, right? Increased phosphate, etc. that is filtered. Yeah, we're going to see them increase in the urine of this patient. Yeah, so that is going to lead to, and that is a major difference, right? That helps you biochemically or laboratorily, right? Differentiate between prerenal and renal. Postrenal, which is going to be due to obstruction. So in postrenal, there's going to be an obstruction in the renal tubules, in the conducting pathway of the kidneys, either in the renal tubules, either in the urethra. There's going to be an obstruction. If there's an obstruction, there will be filtration, but the urine can't go downwards. So what happens is that when urine backs up, there will be pressure, right? So the oncotic pressure, the hydrostatic pressure in the Bowman space, is going to rise. So GFR is decreased, but the mechanism here is due to increase PBS. The hydrostatic pressure in the Bowman space is going to increase, it's going to rise. It's going to rise because of what? There's backup of urine. Urine can't flow downwards because of obstruction in the collecting system of the urinary tract. In this case, initially, reabsorption will be intact. So initially, reabsorption is intact early on. Later, reabsorption is going to be decreased because early on, initially, the renal epithelial cells are still fine. Their absorptive function is still going to be normal, it's still going to be intact, right? So reabsorption of all the filtered electrolytes and co will keep going on, but later on, the backup of urine is going to be toxic, right? It's going to damage the epithelial cells, and that's going to lead to what? Decreased, right, reabsorptive function, right? And then the labs will eventually look like what? Somebody with renal AKI. So these are going to be right. This is the a brief pathophys, right, of acute kidney injury, as simple as possible. Linking what we just talked about, right, with the pathologic changes or lab differences you're going to see, right, to recognize AKI. Here, still definition of AKI, creatinine greater or equal to 2.3 milligram per dl over 48 hours, urine output less than 0.5 mils per kilogram per hour for at least 6 hours, and urea for more than 12 hours. As you can see here, the investigations that will be done in a patient with suspected AKI can give us an idea of the most likely cause or mechanism of acute kidney injury. So we're looking at things like BUN creatinine ratio, urine osmolarity, urine sodium, fractional extraction of sodium, fractional extraction of urea, urine specific gravity, and all that. Urine osmolarity, sodium, FENA, fractional extraction of urea, and urine specific gravity, they tell you about the absorptive function of the kidney. Reabsorptive function of the kidney. Right. So if the reabsorptive function is still intact, we know the patient has AKI because BUN and creatinine is going to be elevated. But if the kidney still has normal absorptive function, there will be reabsorption. Remember, in prerenal, the problem is decreased renal blood flow. It's going to activate the RAS system, and since the epithelial tubules are still intact, reabsorptive function is still intact, though the filtration is low, right? So BUN is going to be reabsorbed more than creatinine. That's why the ratio is going to be what, greater than 20. Also, water is going to be reabsorbed. So most of the sodium that has been filtered is going to be reabsorbed, and that's why you're going to have urine is going to be concentrated. Osmolarity will be greater than 500. Urine sodium is going to be less than 10 because most of the sodium will be reabsorbed back into the blood to maintain the blood volume. Excretion, fractional excretion of sodium is going to be less than 1% for the same reason, because of increased sodium reabsorption. 99% of the filtered sodium is going to be reabsorbed. Fractional excretion of urea is going to be less than 35%. You can use this if patient is using a diuretic. Urine specific gravity is going to be greater than 1.018, that is the urine is concentrated also. So all these are going to be consistent with prerenal AKI, which is consistent with the pathophys we established, right? Microscopy, urine microscopy is going to be bland, right? We won't see notable pathologic cast and stuff. Renal, or you can see Yelling cast because of increased urine concentration. In renal or intrinsic AKI, where the mechanism of injury is something affecting the kidney itself, all right, here, BUN creatinine is going to be less than 15. Now, the kidneys has lost its reabsorptive function. We know filtration is low, reabsorptive function is also low in renal AKI, right? So here, filtration is, filtration is going to be decreased, but reabsorptive function is still intact. Still intact. Right, in prerenal. In renal, GFR is also low, right, but reabsorptive function is also what decreased. Because the epithelial cells, the renal tubular cells, epithelial cells are actually what injured here, right? So BUN creatinine is going to be less than 15 because we cannot reabsorb, right? BUN at the expense of creatinine, right, to maintain blood volume here, right? Osmolarity will be right less than 500. Urine sodium is going to be increased. Fractional extraction of sodium is going to be greater than 1%, that is less than 99% of the filtered sodium is going to be reabsorbed. Fractional extraction of urea will be greater than 35%. Urine specific gravity is going to be also dilute because of decreased water reabsorption, right? So in renal intrinsic, the microscopic finding is going to be key in telling you the most likely cause or diagnosis. If we see muddy brown dark pigmented cast, we're thinking acute tubular necrosis. So the sloughed off necrotic epithelial cells are going to cause muddy brown dark pigmented cast, right? Sterile pyuria or eosinophils, right? It's going to be acute interstitial nephritis. Hematuria, red blood cell cast, dysmorphic red blood cells, acute glomerulonephritis, the most likely cause of intrinsic AKI. If we see pyuria or positive culture, that's going to be most likely pyelonephritis. Postrenal, acutely or initially, somebody with postrenal AKI, the mechanism, the labs looks like prerenal, because initially the GFR is going to be low initially because of increased
hydrostatic pressure of the Bowman space, but the reabsorptive function is going to be intact acutely, right? So the labs looks like, or laboratory findings or urinary disease looks like Prerenal AKI, but later on the backup of urine or urine that is in stasis is going to damage the epithelial cells. It is toxic to the epithelial cells, so epithelial cells are going to lose their function eventually, right? And that's going to lead to what? Decreased reproductive function chronically, and then the labs will look like what? Somebody with renal or intrinsic AKI. Yeah, if we do microscopy for postrenal, if we check the urine microscopy in postrenal, it's going to be bland. Also, you might see hydronephrosis on ultrasound, right? So things like benign prostatic hyperplasia, renal stones, right? They can cause postrenal AKI. Thank you.